health system, and to understand how to build workforce resilience and ensure staff are equipped to handle times of crisis, especially now in times of burnout. As mentioned before, these were our 4 sessions that we've had up until now. Our first session was amazing because we had a brief introduction to the age-friendly health systems, but also we had a social worker from Kaiser Permanente, Jennifer Kwok, who shared with us how to integrate social workers into their model. Then we had our second session that focused on the patient side of AFHS, and Dr. Alice Bonner from the Institute for Healthcare Improvement talked to us about how to prioritize what matters most to the patient. And then Diane Mariani from Russian University talked to us about the importance of focusing on and supporting caregivers. Last session was with Dora Fisher from Haney's in New York, who talked to us about a case study, specifically how New York State was able to make all of its health systems age-friendly health systems. So let me continue sharing my presentation. Today's module 4 want to focus on BJEDI and workforce resilience. And our first speaker is Dr. Jane Carmody, who is a senior program officer at the John A. Hartford Foundation, which is a national private foundation dedicated to improving the healthcare of older adults. Her portfolio of grants includes programs to create age-friendly public health systems, strengthen community-based services for older adults, disseminate dementia care programs and resources, and improve emergency department care and surgical care for older adults. Please join me in welcoming Dr. Carmody here today. We're very happy to have you here, Dr. Carmody. If you want to share your screen, mine will.
I'll go ahead and get started. Yes, right, and right there, and share. And do you see? No? You
yes,
okay,
we do.
Because I won't be able to, thank you so much. I got a little help here from our program associate, Jiho. So thank you, Jiho. I think we're going. Isabel, I have loved these modules. They have just been excellent. I was able to attend most of them and listen in, and so appreciate you doing this. And we're excited. I am excited to be here today with the slate and be honored with the slate of panelists that are here today as well. And as Isabel said, I'm a senior program officer with the foundation. I'm very proud to be supporting the GWEP work. We support the AGS, American Geriatric Society, for a coordinating center and council to support the work. And we're so pleased that they're focusing, and you're focusing on age-friendly care. The John A. Hartford Foundation, and I'm going down, and how come it's not going down? Let's see. You are screen sharing, yeah. Isabel, any hints on how come I can't make it? There we go. Maybe it was just a little slow. Okay. Well, I'll keep trying. The John A. Hartford Foundation is a nonpartisan national philanthropy. We're based in New York City, but we fund nationally. So we fund national events to make a national impact. I'm pleased to be here today, and Isabel, thank you for doing it. I send my regards from Dr. Terry Fulmer, who had kindly suggested that I could help support today, as she is out and about in Utah, providing sessions at a large convening of services for older adults that I think they call them snowbirds. So I'm really excited to be able to do this today. The mission that our foundation has is to improve the equitable care of older adults, and we focus in 3 main areas: creating age-friendly health, supporting family caregivers, and improving serious illness and end of life. These areas are overlapping and interconnected by a common goal, common aim to make sure all people, as many as possible, receive age-friendly care focused on what matters to older adults and to their families, therefore creating equitable care. Next slide, please. The official statements that the foundation has placed around justice, equity, diversity, and inclusion is on our website if you want to go in and look at it. But we commented on the words of the Surgeon General that we cannot stop until we all live with safe dignity and respect. And in some cases, we've elevated that word respect to revere. And the next thing that the foundation noted is that they will continue to review and improve our internal processes. Our staff review our requirements for grant proposals related to diversity, equity, and inclusion, and continue to fund organizations that place racial equity at the center of their work. We will learn from our grantees and partners and do all we can to dismantle racism. The foundation is doing is staff surveys, education. I'm actually on our internal DEI committee. We have a commitment to promote team respect, kindness, and belonging. We add the word belonging, but when we looked at BJEDI, we understand that's a B lab. Is that correct? And the justice, equity, diversity, and inclusion. But lots of times we've seen the B meaning belonging. It's one thing to invite people to the table, to invite people to the dance, but it's another thing to actually engage with them, help them feel like they belong. So that's another term that we use a lot. For our communications, we have a very strong communications team, and it is focusing on all things justice, equity, diversity, and inclusion. And then we have, as I noted, we're making grant requirements that serving diverse populations, reaching diverse populations is all part of the grant. So next slide, please. Oh, I guess I don't have to say next slide. I'm doing it. The foundation has a number of blogs and statements that are listed here, and we'll be sharing these slides, Isabel, as well. So they will be able to click onto these, and they'll be able to get these articles if they haven't already seen them. Thank you. And so, as you can see, we have an active communication to support and to let people know of our work here. And then we disseminate a number of the grantee JEDI resources. And so here is a number of those publications. And I can kind of point out a lot of the work that that Trust for America's Health is doing, and our dear Dr. Phillips will be speaking next about that. But again, some more examples of some resources that might be helpful to people. So early on, the foundation leadership and team required diversity, equity, and inclusion in all grants. Now, it always has been there, but we don't know that it was there with the emphasis that we've had. So we've added that DEI information and best practices has to be shared so that we can all learn from each other, that discussions are embedded in the annual review site and agendas. So the foundation funds a number of grantees, let's say about 50, 60 in the course of a year. Every one of those has a site evaluation that we invite a consultant, objective person to come and review the progress of the grant, as well as a guest, as well as our whole team, and sometimes our board members. And all of those, what has to be embedded into that site eval is the work that they're doing around diversity, equity, and inclusion. And then all external grant reviewers, the consultants I mentioned, are asked for recommendations around this work. So next slide, please. I listed here a number of our grants, grantees that have significant activity with diversity, equity, and inclusion. As I said, I mentioned Dr. Phillips will be talking about age-friendly public health. I'll talk about the EDs and the ORs and US Aging, AARP, Diverse Elders, the National Medical Association. All of these have a focus on dedicated streams of work to focus on DEI. One of the things that we always consider first when we think about the inequities here, that ageism is another contributor to inequities. And it has a multiplier effect for people who have been subject to a lifetime of inequities, of disparities. As we say, disparities do not improve with age. So to that end, we support the Reframing Aging effort, which the American Society for Aging has been a part of. I mean, geriatrics, it's not ASA, it's Gerontological Society of America has been a part of their long-term social endeavor to improve the public's understanding of aging, what it means, and the many ways that older people can contribute. So we think of this across all of our work. And so if someone's new to aging or working on aging, there is ample evidence to show that ageism has a real and negative impact on health. And 1 in 5 adults report experiencing ageism in healthcare, and it leads to both undertreatment and overtreatment. We all can play a role in redefining aging and the negative biases against getting older. And you can start yourself by talking about aging as a natural, lifelong process that unites us all. We're all aging, and not talking about aging as a problem to be fixed. It's not a diagnosis to be fixed. Aging is not a disease. It is not a diagnosis. So one of the things that you would hear if you were attending Reframing Aging is that one of the easiest things you can do yourself is to say, not talk about aging as if it's, a disease or something bad, such as birthday cards that you send out. I stay away from any cards that indicates the negative impact of aging, or saying someone's 90 years young. So you can get help and learn more from the initiative we support, and a lot of resources that they have, and new resources. They have facilitators in about every state, and a really good place to start in terms of aging and reframing it. Also, much of this work is by the Frameworks Institute, and they have covered a number of other diversity, equity, and inclusion topics. Next slide, we're going to talk about is age-friendly health system, because that is really what Isabel and team are trying to review with you today. And just a few highlights of what's going on there is the Equity Task Force formed in 2020, and they're starting with measures and data collection. That was something that we asked grantees, well, how many diverse populations are you serving? How many, we knew how many older people we were serving, but not necessarily in diverse locations. So that's when starting to collect that data, and starting from there, recording the racial and ethnic breakdown of patient populations, and linking that collection to quality measures, and analyzing the outcomes and taking up action. There's some links in here that you can look at for a Health Affairs article about that very thing. And the next slide, we'd like to show that as far as age-friendly care, which starts with What Matters, is reaching about 1.6 million older adults, which is probably an underestimate. Because starting with where the person is, as with What Matters, is what we think is the best way to start to address what a person's particular needs are, and in diverse populations. We work closely with diverse elders, and maybe some of you are familiar with them or very familiar with them. Diverse Elders Coalition consists of organizations representing 6 groups, and I've listed those there. And they give us great, there's free online training for healthcare and social service providers. We have referred them to some of our other grantees and work alongside with them to make sure that the work that they're doing, the programs and services they're developing and building, are really meeting the needs of these diverse populations. And we love the work that they're doing. We love the input that they have, and we have changed a lot of programs our grantees has in terms of the care that the services they're developing. Now, this is family caregiving for diverse elders, which was another grantee of ours, which was the AARP, which is deeply committed to caregiving issues, and they partner with the National Alliance for Caregiving to produce a report every 5 years on the state of caregiving. Now, of course, in here now is that we're trying to really also then focus on the diverse population, and making sure that diverse populations and having those numbers. For example, African-American caregivers have been caring for 5.2 years on average, more often in high intensity situations than the rest of the population. So that's the kind of information that we're gathering, and the information that helps us develop programs to improve. Okay, we'll mention US Aging and its Aging and Disability Institute. 80% of our health is driven by the community where we work, play, and pray, the social determinants of health. 90% of us want to stay home as we age and as we die. And so this is an important effort of ours to support and strengthen community-based organizations, the AAAs, the Area Agencies on Aging. And we work closely with them. We have for years. I think we're going on to maybe our 9th year in working with them. And we also developed the John A. Hartford Foundation Innovation Award to encourage and highlight organizations that are really doing a great job in terms of innovation and innovation in their communities. We have aligned them with the 4Ms. It's kind of a common language between them and health systems. And they have a diversity task force and a collection of resources to develop diverse leaders within their AAAs, improve culture awareness, and reduce disparities. As they note, minority older adult rates are expected to rise by 217% in the decades to come. I will mention that there was a crosswalk of the 4Ms with the evidence-based programs that the AAAs are providing. And all AAAs have to offer 5 core services, and the programs that they've provided have to be evidence-based. So there's been an alignment with those, and 4Ms has become a common language. So the work that they're doing has been great. Next slide. So some new grants that have and projects that are in process that really highlight some of the work that we're doing and how it's aligned with age-friendly health. And that is there's the American Society for Aging. RISE is to support leaders of color in the aging field. We're excited about this work. They have a great cohort of leaders right now. The Center to Advance Palliative Care, or CAPC, is addressing palliative care for Black Americans because very few are a much smaller number of Black people in the United States are receiving palliative care. We have a funder collaborative with 7 other funders that focus on complex care and the Better Care Playbook, which is available to all. All of the things I talk about are available because we're funding and supporting. They're available for your use. We also support 4 core operating grants to advocacy organizations like the Center for Medicare Advocacy, Justice and Aging, Community Catalyst, and Professional Healthcare Organization, or PHI. So we also have supported and learned about the National Medical Association. This was created by Black physicians who were barred from the AMA. So as you can imagine, the history on that is quite horrendous. Next slide, please. So we have age-friendly care, as I mentioned, in the EDs. We're supporting efforts there. They're part of their goals in each of these, the age-friendly ED, the ED Emergency Department accreditation, and even with our work with the American College of Surgeons in the Geriatric Surgery Verification Program, all have a focus and an effort on tracking and enriching diverse populations written right into the grant. As we suggest here with these various age-friendly care programs, there is no wrong door. You can work with any one of this and lead to an age-friendly health system, or age-friendly health system and lead to this. I did want to mention that other aspects of some of the age-friendly care programs we have. Hospital at Home is a wonderful program. There's discussion about it a little bit and how they work with family caregivers, but that's being addressed. But one of the things is we want to make sure that it does reach diverse populations, because we don't want people to be excluded because someone thinks that this home or that home is not appropriate. Next thing we also support is best practice caregiving, and this is a selection of about 44 proven programs to help dementia family caregivers manage, the work and the love before them. This is a grant that we've added Diverse Elders Coalition, because as they're going to work now on a consumer version, this version was for professional organizations and health systems to pick up and to develop and make available to family caregivers. The next version will be to go directly to consumers, and that's where Diverse Elders Coalition is working closely and partnering with Best Practice Caregiving team. And then I mentioned the Alzheimer's and Dementia Care Program at UCLA, where they're addressing diversity in dementia, and part of that starts with diagnosis, which this program has really helped to improve. This program, as for example, is also listed on Best Practice Caregiving. Best Practice Caregiving covers the range of dementia from mild cognitive to the more severe, which the Alzheimer's and Dementia Care Program at UCLA provides, a 24/7 support from a nurse practitioner. So the challenges that we see is that it's a journey. It requires ongoing attention. You can't say, oh, we did it, we're done. Much to do with our internal processes. Major improvement is needed for healthcare equities. And as our president and our vice president, Ronnie Snyder, says, no effort is really enough. The opportunities we see is that we have a higher awareness and commitment, as do others. We have an all teach, all learn approach. That means partners and grantees all guide, and we learn from each other and our internal and external work. It is a good time. It's ripe for improvement right now, meeting needs of diverse family caregivers, for example, and any effort toward a more just, equitable, age-friendly care is worthwhile. I want to mention a couple of quotes. I love to listen to quotes. They mean a lot to me. So I have read this before, that whatever we do for one, for the most vulnerable part of our society, we do for all because it benefits all. If it's not morally right to some people, because the cost of not doing so is far greater. And of course, Martin Luther King said, of all the forms of inequality, injustice in healthcare is really the most shocking and inhumane. So one of the things that we look at always is an age-friendly ecosystem, how all of these parts work together. And we also think about that in terms of justice, equity, diversity, and inclusion, that the solutions are for all. As said before, if you solve a issue and a problem and a challenge or a barrier for one, for the most vulnerable, it helps all. So I always bring up the curb cuts. This curb cuts, what we're all used to now in our cities, is easier for a wheelchair. This was an activist named Ed Roberts who started this work, and he complained about it, and he was in a wheelchair, and he said it was blocking his mobility. And one of the 4 M's, of course, is mobility. And he was central to the movement. And this shows you what one person and one city did, and now we basically see it worldwide as well as in the U.S. I do want to notice here this little Moby mat, and maybe Dr. Phillips is going to talk about this. We always show it. Our work in Florida was to engage public health in aging, to have it become a core component. And one of the counties developed this Moby mat. They wanted people with wheelchairs and walkers to be able to get to the water, not just look at the water. And if you're ever in a meeting in Florida, they all brag about their coasts and their beaches. And anyway, so this is a Moby mat, but as you can see, the picture that is on this one is that it was good for families as well. So as you can imagine, that whatever we do for the most vulnerable is done for all. For all, we have to all work together to improve diversity for all, equity for all, and inclusion for all, and make sure that we also make sure that people are belonging. And that's what I have, Isabel, and I'm glad to turn it back to you to hear the other panelists and look forward to more discussion.
Perfect. Thank you so much, Dr. Carmody. This has been amazing. And I'm very happy to introduce our next speaker, Dr. Caron Phillips, who is the Policy Development Manager at the Trust for America's Health, where she works with the Policy Development Team on the Age-Friendly Public Health Systems Initiative. Dr. Phillips has been engaged with the field of aging for over 15 years. Most recently, she served as the Program Manager for U.S. Aging, formerly N4A. In this role, she developed contact and resources for Engaged, the National Resource Center for Engaging Older Adults. Prior to her work at N4A, she served as a Scientific Review Officer contractor for the Center for Scientific Review at the National Institutes of Health, the NIH. In this position, she supported the scientific review of research grant applications made to the NIH. She also has experience leading the implementation and services focused on health promotion, including chronic disease, self-management, and falls prevention, and developing new partnerships to provide community-based services to older adults. Welcome, Dr. Phillips. Thank you for joining us. You can share your screen if you want, or let me know if you want me to move on your slides.
All right, thank you so much. I think I'm going to share my screen. I think I'm all set up. I've got all these moving parts. Let me make sure I have. Okay. All righty. I think I need to just that. Is my screen coming in? Okay. Yes, wonderful. Well, thank you so much, Isabel, and It's always a pleasure to present with Jane. And again, I enjoy sharing about H1 Public Health Systems work, and especially focus on diverse and equitable solutions as well. It's funny, Jane mentioned the Moby map. That I used to live in Florida. I've never seen one, so I'm hoping I get to see one in person soon. But yes, as you mentioned, it wasn't just something for older adults. It was something that people across the lifespan used. Moms would take their strollers down, and when you're going to the beach, one of the worst things is trying to get your your cooler and your toys and whatever you want to take down there with you. And the worst thing that could happen is you don't have the space for it. So yes, it was those are really cool. And I thank Jane for also setting the context for this idea of, again, focusing on a life course perspective. So I will not be before you long, but I do have a few slides I want to share. So a little bit about Trust for America's Health. I don't know if some of you have attended or this session before, but my colleague, and I'll call her my partner in crime, Megan Wolf, the Senior Policy Development Manager here at Trust for America's Health, usually also presents. So I'm also honored to present in her stead. The Trust for America's Health is an independent, nonpartisan public health and prevention-focused nonprofit in the DC area. And TIFA overall, we're focused on policy and advocacy with an equity focus. We are committed to improving the health of every community, and we make disease prevention a national priority. A lot of our reports focus on a lot of key issues. We have a Pain in the Nation report. We published an annual State of Obesity report. And again, a lot of this dialogue is focused on research to help advance and address these not only critical health issues, but some of the disparities that lie within those as well. So I wanted to set the context for public health briefly. What is public health? Public health is, as a society, what we do collectively to assure the conditions in which all people can be healthy. Little quick snippet about me. I knew I wanted to work with older adults since I was 15. I know that's a young age to know, but I worked at a geriatric care facility in Atlanta. I was actually volunteering. My mom signed me up to volunteer. And that was the most memorable experience of my life. And I kind of knew that that was going to be my connection to the people that I wanted to work with. But I knew it wasn't going to be in a nursing home setting or in a specific setting. I was really interested, and I couldn't articulate it at 15, but I knew I was interested in public health and health across the lifespan. So I ended up going into graduate school, knowing I wanted to focus on gerontology and public health as my core priorities for a profession. So public health is upstream. Public health is figuring out what happens before we get down to the end, where we're at the end of kind of the preventative measures. You have, your first level of prevention, you have your second level of prevention, and we call it tertiary. We want to try to stick up here in the upstream and the first level of prevention, preventing this man from even falling downstream, and which typically is associated with hospitalization. We want to be up at the front, making sure that we are aware of the challenges that this person is experiencing, so that we can keep them from having further complications. And again, you see the lifelines; those are still the efforts of public health as well. The roles of public health. Policy, systems, and environmental change. One big thing, and I promise I won't get off on a tangent too much today, I love talking about the value of having really good quality data. I used to work in affordable housing, and one of the things that we often lacked was having data on the health of our older adults that we worked with. But once we started to formalize that and actually collect information on the people that we were serving, we were able to develop unique partnerships and really start to get at some of the disparities that we were experiencing and understand the disparities that we were seeing. And I'll get a little bit into that later in my talk. But public health can also help build systems of care and support, deploy the strategies of disease prevention and control, establish models of policies, demonstrate a viability of new approaches. I think, again, I'll try to highlight this again later on, but we learned from the pandemic a lot of innovative and I would say, collaborative ways to address a lot of the challenges and the disparities that we were seeing out of necessity. Again, this is many people's first pandemic. So for a lot of us, we had to reinvent and reconfigure and realign to be sure that we were supporting our communities. Disseminating information in health education, convening allies and partners in collaborative initiatives, community engagement, and then safety net and gap filling services. So this all, again, the roles of public health. So as we consider, I always like to tell, I also teach on the side, I always like to tell everybody, we're moving from that lovely pyramid to this rectangular shape. So I always tell people, even if you're not interested in working with older adults, you need to be mindful of the fact that there's going to be almost somewhat of an equal ratio of everyone in the population. We're having slightly fewer children and people are living longer, hence this round, almost rectangular as opposed to population pyramid. They call it from a pyramid to a pillar, actually. It's a great way of explaining it. So the health needs of older adults, we know that they're at least 80% have at least one chronic condition, and that about 68% have at least two or more chronic conditions. And these range from not only just hypertension, high cholesterol, but also depression. And again, we are becoming keenly aware of, again, the rise of other conditions, but also keenly aware of the importance of addressing Alzheimer's disease and dementias. So here at TIFA, I am privileged to work in our age-friendly public health systems initiative. Again, it's funded by the John A. Hartford Foundation, as Jane already mentioned. And the short of a very long is our work is focused on making sure that public health and healthy aging, more specifically, is a core function of public health departments across the country. That is the short of a lot of our work, but we do this, and a lot of our work is guided by our 6 C's framework. You all are privileged to get to hear us talk about this. Actually, this framework was revised. It used to be 5 C's. We used to have 5, but we added a 6th C to really highlight and emphasize the need for leaders and champions, as we call them. So our 6 C's, again, was revised earlier this year, and they're focused on, the first one, actually, to say the newest one, is creating and leading policy systems and environmental changes. This one, again, really focuses on having a champion at the table, having someone that is the voice that can help usher in and express the importance of healthy aging. And again, I will stress, this is a life course perspective. This is not just subject matter expertise in aging. It is a life course perspective. We want to make sure that we're not only thinking about equity, but we're also thinking about equity within a life course. So we have collecting and leading, and we have creating, then we have collecting, analyzing, translating relevant data. I've told you all, I love talking about data, but and the importance of it. More of the fact that data is used as a tool and a resource to help usher in new ideas. And when you sit down and you start to understand and see what the picture is telling you about the issue, you can fully understand what needs to happen next. And you can bring other people to the table as a result, which leads into the 3rd C, connecting and convening multi-sector stakeholders. Everybody should be at the table. Aging should be at the table. Public health should be at the table. Nutrition programs should be at that same table. Everyone should be at the same table. Health equity related entities or in programming should also be at the table. Communicating important public health information, again, that is obviously key and a lot of a core of what public health does. Coordinating existing supports and services. Again, one of the ways that we work with various departments of health is that we tell them, don't reinvent the wheel. If there's a program, for example, and this actually happened quite a bit during the pandemic with several entities, if there's a program that exists and it currently serves, let's say, mothers and children, why not expand it? Why not offer it to older adults as well? What we found is that during the pandemic, people were able to bring together I'm just going to use the term lightly, kind of food coalitions. And they brought together different programs that had resources to distribute food. Because again, food challenges were quite evident and quite obvious and exacerbated by already existing disparities. But again, if you bring together people that have access to these programs and you all come to the table, you can reach a broader audience. You can reach more people in the community. You can actually serve your entire community, not just a segment or a specific demographic. So coordinating existing supports and services, again, what are you already doing? We encourage departments of health to review what they're doing and then see how they can enhance and offer them to the people across the life course. And then complementing those existing health programs. What else can be done? What else can be added to enhance them, to make them more supportive? So public health needs for older adults. Again, we're focused on prevention and access to other quality health services. We're talking about healthy and affordable foods. We hosted a training last month where we talked about what's being done to address food insecurity. Food insecurity is a very challenging topic for many older adults, especially in diverse communities. And it's important to think about ways to equitably address getting food out. I think the assumption is that people have access, but again, it could vary. In addition, also considering things, and this is actually a true story. I used to work in affordable housing, and the older adults sometimes didn't know how to prepare food, or they physically could not prepare food. So they would trade their fresh produce boxes for food that was already prepared, and it might not be the healthiest thing for them. So figuring out how to help them prepare food, but all maybe figuring out how can we maybe help them with a volunteer or whatever the case may be, that's what we had to do. But again, having access to healthy food and then affordable, it's again, a very important need. Physical activity, again, focusing in on evidence-based programming that specifically helps older adults to become active. There's a lot of physical activities that have equitable lenses and understanding preferred practices for various communities, preferred activities. It's interesting because I've been watching this group and I really would like to meet with them, although you have to be of a certain age to join it. But there's a Double Dutch Club. I don't know if you all have heard of them, but they're actually kind of it's become a bit of a national movement, and you have to be at least 40 to join. But they get out and they do double dutch, they jump rope. They do a little bit of line dancing as well. But again, it's a nod to previous previous activities of youth. I know I grew up in the double dutch jumping rope era as well, but you have to be a certain age to join these groups. But again, that's the goal, that tobacco and substance use prevention saw trends with this in the pandemic, that there was an increase in substance misuse related to social isolation. Social and emotional support, again, making sure that people are connected to not only resources, but also people. One of the key things that has been happening, again, as a result of the pandemic, is that people have been relying more on virtual resources to provide activities for older adults. However, keep in mind, not only do we need to consider having broadband access, which is a really big and very important hot topic, as I call it, but also keeping in mind the having access to a device, and even having access to, again, the broadband, but even in the sense of the desire to use it. So we also have to keep in mind other interventions that are not just necessarily technology-based. Violence and abuse prevention. June 15th was Elder Abuse Awareness Day. And again, we've seen an increase in this recently unfortunately, during the pandemic. And then social determinants of health, housing, transportation, built environment, making sure all these things are not only appropriate, but supportive for older adults. So how can age-friendly public health systems, how can all this that I've been talking about lead to improving older adult health outcomes? It can promote equity. Again, we saw the disparities across all different domains, especially related to social determinants of health during the pandemic. By bringing partners to the table, by leveraging existing resources and collaborating and developing new ideas and relationships, we can then begin to reach larger groups and start to eliminate some of these disparities. Change the social determinants. 80% of health outcomes are determined by these factors. So again, housing. I attended a housing summit last week, and again, how are we providing equal access to housing? Housing is challenging. I don't know if you all have seen there was an NPR post, I use Instagram, and it talked about the different rental rates across the country. And I'm just thinking, who can afford this? So how are we providing housing solutions to older adults? How are we providing transportation options? Again, one of the projects that we worked on during the pandemic really looked at vaccine access and how do we get vaccines out to older adults and people that are unable to leave their homes. And there was a lot of innovative solutions that had to come out of that, a lot of different partnerships that had to be created and start to develop because of the fact that there were people that could not get to a vaccination site. I mean, it may sound simple, oh, just go get a vaccine, but what if they can't drive? What if their caregiver does not drive? What if they don't live near a bus line? These are all legitimate factors. And then strengthening partnerships. Collaboration is crucial for collective impact and can reduce medical cost burden. Again, working within different systems. Public health and aging have traditionally operated pretty separately, with the understanding that, well, they understand aging, we understand other areas, but the two together can accomplish many, many things, and again, address a lot of these issues of disparities. Showing our framework again, but again, emphasizing here that at the core of all what we do is health equity. I should also mention that one of the things that we have really been focused on lately is our recognition program. And we are really in tune to recognizing the great work that's being done at departments of health to support older adults in the community. So we have a recognition program that's based on the 6 Cs framework. So what we have people do is, or not people, but departments of health do is submit an action plan based on these 6 Cs. And so they'll talk about what they've done related to these key areas. I will put in a little plug if any of you are ever interested. We have a designation under our recognition program we call APHIS Champions. Anybody can become APHIS champion. Anyone can become an age-friendly public health systems champion. We have monthly trainings every month. They're traditionally on the third Thursday. This month it was on a Wednesday, but they're traditionally on the third Thursday of the month. And we cover a variety of topics. This year we're focused on social determinants of health. So as I mentioned, we focused on food insecurity this month. Last month we focused on data. We focused on, I'm drawing a blank. There was a connection to housing. We focused on data access, but again, all of them are recorded as well, and we archive them on our YouTube page. If any of you are ever interested in becoming APHIS champion, please let me know. But for the departments of health, we again, once they complete an action plan and indicate the activities that they have done or planning to do related to these 6 Cs, we recognize them as champions, and that's all logged on our website. So just a few more slides. Jane already mentioned the ecosystem, but I want to just highlight how there's this whole ecosystem of age-friendly best practices, and it involves a lot of different entities coming together to deliver and provide resources and services. So you have obviously age-friendly public health, and we have age-friendly health systems. We also have age-friendly cities and communities. That's the AARP designation that many states have. I live in a county that is an age-friendly county. There are now age-friendly employers. That is a relatively newer designation that employers can receive, and universities as well. The University of Maryland, Baltimore has a center now that is an age-friendly university. So again, it's a whole age-friendly ecosystem of opportunities and collaboration that can occur across these lines. A lot of times when we work with departments of health, we learned that they're in a city or a community that's an age-friendly community designated by AARP, and there may be an age-friendly health system nearby as well. So they already got a great network that they can access and again, to help connect all of this age-friendly content. And some last pieces, I'm going to give you some practical examples. So again, there's my data, equity and collaboration. We began this work for the age-friendly public health systems in Florida. And Florida has data profiles that exist on each of the counties. These profiles are recently expanded to include information to help address health disparities by expanding their information on race and ethnicity. Again, understanding what disparities look like can help you more strategically align what needs to be done in these communities. So we started our work in Florida. So we have two grantees that we work with. One is the state of Mississippi, and in Mississippi, the other is Washington, but in Mississippi, they have actually begun also develop their own data profiles to, again, address their disparities, but they're in their project, their overall project to incorporate an age-friendly public health system into their work. Mississippi has been collaborating with the Office of Performance Improvement and the Office of Health Equity to promote older adults in their strategic planning process. And again, one of their key areas is health literacy in the area. I'm not sure if any of you are familiar with the Mississippi Delta. I had the opportunity to go and meet with Mississippi earlier this year and really learn a lot about some of the disparities and challenges that exist in the Mississippi Delta. So this is a unique opportunity to really begin to address some disparities at a literacy level, but also for a whole strategic plan. They have actually developed a work plan that they're going to be implementing over the next few years to, again, implement age-friendly public health, but also focus on equity-related solutions. And finally, partnering during the pandemic to address social isolation. Seattle, Washington State's Department of Health, they provided senior congregate meal sites with recommendations on how they could modify operations. So again, the health department is sharing, this is what's going to help you with your operations of these meal programs at the site level. And also, in reflecting back up, the Seattle King Area Agency on Aging provided their template on how they communicated with Washington's Department of Health recommendations to their network. So again, showing again how these two entities that typically in the past have not worked together, but again were brought together by the pandemic, but also again showing and highlighting how they could use their different resources and their different expertise to help each other become more aligned and work with older adults. And with that, I am done. Here's my contact information. If you ever have any questions, I'm happy to talk about any of the things I mentioned. I'm always happy to talk about aging and health equity. And please visit our website. We always are updating it with a lot of tools and resources. You can find out more information about our recognition program and our trainings there as well.
Oh, thank you so much, Dr. Phillips. We really appreciate it. And I know that people are engaging in the chat and that Dr. Pandya asked a question about engaging students. And we will definitely circle back to that and answer any other questions you may have. But I want to be able to introduce our final and great speaker, Dr. Marie Borgella, a nurse and director at Massachusetts General Hospital. Dr. Borgella has led nursing teams specializing in general medicine, oncology, critical care, psychiatry, and substance disorders, all while working part-time at the Massachusetts General Hospital since 2002. In 2016, Marie completed a Nurse Manager Leadership Academy program at Johns Hopkins Hospital and earned her doctorate in nursing practice from the Massachusetts General Hospital Institute of Health Professions. Her doctoral capstone focused on how do we bring joy, employee engagement, wellness, well-being, well-being and longevity in the workplace. Marie's passion is to lead diversity and inclusion initiatives, serving underserved communities, and volunteering services in the community around vaccination efforts and preventing the spread of COVID-19. So welcome, Marie. We're happy to have you join us as our last speaker today. I know I'm going to be sharing your slides, so please let me know when to move along.
Sounds great. Thank you so much. Greetings to all of you. I'm so thrilled to be with you all this afternoon. As Isabel shared, my name is Marie Borgella. I'm a nurse director on a general medicine unit at Massachusetts General Hospital, or Massachusetts General Brigham, since we are now integrated. I feel so honored and privileged to be amongst all of you. And also thank you, Dr. Komati and Phillips, for your presentation. And Isabel and team, thank you for having me in the space today. First and foremost, I want to share my experience working as a nurse leader while always promoting the acronym of JEWEL, which I will be talking about. Also, I'm thrilled to have the opportunity to include workforce resiliency and creating a sustainable system in times of crisis in today's discussion as well. I do want to take a few minutes to talk about my doctorate work on JEWEL, which focused on creating and sustaining a culture of joy, employee engagement, wellness, emotional resilience, and longevity. And each of the words in the bundle represent what we need to create a workforce of resilience. So when we think about what is the purpose of creating and sustaining a culture of joy, employee engagement, wellness, JEWEL, I would refer to. Well, we know that the COVID-19 pandemic not only presented mental health stress points to all our healthcare workers, such as making it difficult decisions about how to conserve supplies, prioritize treatment, and also putting their friends, colleagues, and most importantly, families at risk for exposure to the virus. So we know that that presented a lot of mental health stress. So under these conditions, our healthcare heroes that we refer to are likely to increase and anxiety, depression, trauma, burnout, and other health issues. So prior to COVID, next slide, please. So prior to COVID, what I did was I sort of studied some of the inpatient care units research and also realized that healthcare workers, nurse practice setting is emotionally, mentally, and professionally challenging. While it was clear at the time that nursing in the hospital setting can be stimulating and a rewarding career, there were risks of frequent contact with serious illnesses, trauma situations, pain of patients, having to watch patients suffer, and helping people cope with death. And other things that I was able to land on was research studies have highlighted that the stress, grief, and solitude of caring for terminal and critically ill patients can also create an environment of depression, hopelessness, and increased staff turnover. And one of the things that really captured my attention as nurses do report to me was that they are at high risk for, of course, compassion fatigue, professional burnout, and needed support and education at every single level to help them strategize on how to best care for our patient. So therefore, I went on to do my doctorate work and focusing on identifying tools, strategies, and resources to help create and maintain JEWEL. Also, as an example, we can to the next slide for the framework. As an example, next slide, please. Thanks. So one of the things that I used to help with this was the method I used was the Joy at Work scale that was used to measure joy across the three discrete dimensions: meaning, engagement, growth, compassion, sensitivity, respect, and trust. Next slide, please. So what I did was these were the questions that we asked, very, very hard to read, but I realized the meaning of the work that I do. When I'm working, I forget something around me. I experience a sense of delight at work. I feel proud for the job that I do. My learning and growth is interconnected with my organization, mission, and vision. So I'll let that slide stay on for a second. So when we use that slide, it's sort of, when we use that Joy at Work scale, it sort of helped guide what exactly matters to the staff. What exactly do they need to have an environment, not just healthy, but they can feel fulfilled with, engaged in different organizational mission, vision, and feeling well, feeling great about the work that they do. And then the longevity aspect is, how do we keep nurses, whether it's at the bedside, whether it's at advanced practice profession, or whether it's becoming a CRNA, but stay in nursing. Do not leave the patients. So I really appreciated the method piece of using the Joy at Work scale. Next slide, please. And then in terms of my theoretical framework, I use the Happy People Productive People frame, the Happy, Healthy, Productive People framework, which also derived from the IHI. It served as the model that pretty much guide the aspect of joy, employee engagement, and wellness, and emotional resilience and longevity. If you look at the framework, at the very top, it has senior leaders, and then it has me, and then it has the individuals, and then everything else that pretty much refers to the bundle. And also research has demonstrated support for each concept in that bundle, intertwined or linked. For example, bundling work engagement, employee commitment, and employee association with well-being and healthcare showed significant result, as the research showed. The other thing too, the goal was to also study whether work engagement and work commitment can be scientifically separated, and how each is associated with well-being. So it was extremely important to ensure that these constructs are linked with personal accomplishment, psychological well-being, internal work motivation, mental resources, everything that's encompassed in the theoretical framework wheel that is up. Another study also I examined showed characteristics around decreased work productivity if employees, healthcare workers are not happy and find joy in what they do every day. One of the things that the study suggested, that nurse leaders are obligated to make changes to improve the hospital workplace environment and alleviate stress, improve the quality of nursing care, and also to assure the health and safety of our nurses is key. Ultimately, it is of benefit to implement the Jewel Bundle utilizing the framework of the Institute for Healthcare Improvement. Next slide, please. So one of the things that I tried to do during the implementation of this project was I used a PDSA cycle, and that implemented and tested a series of intervention, as many of you are familiar, or if not, that was the intent. So a baseline measurement of clinician was performed to sort of identify their levels of joy in the three areas of personal, feeling, interpersonal, and perception, and of course the organizational support. And I say personal, interpersonal, because we highly and should encourage everyone to bring their whole self to work, right? To be able to create that psychosocial safety environment, which is part of the IHI theoretical framework that was up earlier. So using the PDSA cycle to improve the project was key for me. Next slide, please. In terms of participants, I had a total of 98 staff. Next slide. And that included 56 full-time RN, 7 full-time PCAs or clinical assistant or nursing assistants, some organization refers to. And the staff had varying levels of education, years of experience in their roles, and also on the unit. The setting was on an inpatient unit, and a total of, I want to say now, maybe 405 beds at Academic Medical Center located in Boston pediatric setting. And so when I looked into the ethical consideration and ensure was, there were no identifying information that was obtained from the participating nurses or clinical assistant in the sample for this project. Clinical staff that reported directly to me served as participants in the study and were asked to complete the baseline and post-implementation survey. Staff members were also told that they had the right to refuse participation in the project intervention or pull out whenever they wanted to. Furthermore, staff were told that they may contact my associate chief nurse, the person I report to, if they felt uncomfortable or if they didn't want to be a part of the project. The surveys were also administered through a discreet, unable to link to staff in any way. The link was sent via REDCap, email distribution list by the program coordinator, and not from me. The data was housed in a password protected REDCap database within the organization firewall. No employee characteristics were able or could feasibly be identified, or any individual employee were captured in any of the demographic questions. The data was analyzed in an aggregate and not at the individual participant level, as there was no way to link baseline and post-implementation survey scores for any individual employees. So we use the Joy at Work scale that I showed earlier to measure joy across the 3 discrete dimensions, like I shared: meaning, engagement, growth, representing personal joy, compassion, sensitivity, respect, trust, support, flexibility. And the scores derived by summing the totality of points across the Likert items. In terms of data collections, we implemented the survey 2018, September 2018, and we pulled down the survey right before Christmas just to get a good 3 months worth of data. One of the things that I was able to come with as a result was there wasn't any significant change between, the staff being more at Joy, because one of the things that I realized, they had the baseline at Joy, and a lot of it was, I didn't know I was going to fully get that result. I thought they weren't joyful. I thought I didn't have enough joy in the environment. So it was great to see there wasn't a shift. And so one of the things they highly, highly recommended is that I kept all the interventions that were implemented. Some of the interventions were, I was able to get a grant through Petals for Pediatrics at the organization I was working, where I was able to get a massage chair and a masseuse, certified masseuse, visit staff, both day shift and night shift. And I created an area for all staff. At some point, it was any staff. It went to any staff because it was such a hot, wellness, well-being. I can't even explain how happy the staff were able to just pull away from their assignments for 10 minutes, just to get a quick massage. They didn't really want to go back to work. As you know, after a massage, that's how you feel. And I also had it in the night, during the night shift too. And it was part of that grant for a wellness and well-being initiative grant. And I just tied it into my Jewel project. The other thing we did was mindfulness activities and also reflection, moments of reflections. And that included just being in a room and just talk about passion, positive reflection on what it's like to be a nurse. How did you get into nursing? Whatever that was, the reflection that that created a space for why are you in nursing? And we had to stay a little bit on the positive side for this particular project, as it was part of the wellness, well-being, and longevity aspect of looking at what else can we do as leaders. So I just want to shift a little bit to talk about, next slide, please, to talk about, I'll talk about the Jewels newsletter in a minute, to talk about, Jewels, between Jewels and then having read 5 Days at Memorial. I'm not sure who's read that book, but I highly, highly, highly recommend reading 5 Days at Memorial, because I think 5 Days at Memorial, after reading that book that book allowed me to lead during COVID time, where many of my colleagues have lost several of nurses to go into travel nursing, and I've only lost one. I opened up Bigelow 7. I opened up Bigelow 7 and built the unit from scratch and hired all the nurses, the PCAs, and several of my nurses have left the unit, not because of, COVID or the experience, because one of the things that I did during the pandemic is we took care of COVID patients when it was time for us to take care of COVID patients, but we also took time out to celebrate us. We took time out to pause. We took time out to have a baby shower, right? We took time out to also celebrate us working during COVID. We always stayed to the basics despite everything else. We had cupcakes events because we couldn't have cake. We continued to work around what was happening during COVID. So 5 Days at Memorial, there's a section there that really, really helped me to sort of think of that, right? I remember there was one section in that hospital where they were having a fashion show during all this, and they were still, in a crisis. So again, they were still struggling with the storm. So 5 Days at Memorial is a book that I think all of us should definitely get our hands on, because it really, really helped guide me in sustaining a workplace, an environment during time of crisis. The other thing is Movement as Medicine. So Movement as Medicine, fast forward to 2021, I have a group of nurses as part of the wellness culture, which is a good way to encourage and spread responsibility of maintaining a high functioning joy, employee engagement, wellness, emotional resiliency, and longevity. Is I have wellness champions, and they're dedicated to identifying, organizing, promoting, and commuting their efforts to the rest of the units around Jewel. So some of it is, for example, we have pet therapy. So we have our pets can't now go to patients because of COVID. Hopefully they start to infuse that, but they come on the units, and my unit once a month, and they spend time with staff, which is, I didn't even think that would bring as much joy, but it brings so much joy to staff to be able to have pet therapy. The other thing we have a small speaker, extremely small, and it stays within the nursing station. And the volume is relatively low because we know that one of our metrics is quiet noise at night, quiet noise during the day, promote sleep for our patients, promote rest. So we have a radio where one of our staff has a Spotify account, and he's created a playlist that's very, very appropriate. And while they're working, they can actually listen to some music in that nursing station that is not loud. The other thing I'm tasked with, and I haven't had a chance to get it yet, is a beta fish, which is of course part of the wellness Jewel culture, to get a betta fish, and I'm hoping I can pick it up this weekend. And we have to name this fish for the unit because it's going to be our fish and our mascot fish, and everyone will be taking care of this fish. It gives all of us a purpose to know that we have a little pet that can stay in the bowl that we'll be caring for. And then we've had other off-unit popular initiatives as well. Paint night, the typical axe throwing, movement class tonight. We've had cooking classes, how to make dumplings, and staff are really engaged on these little small activities of bringing everyone together, engaging everyone. The other piece that I definitely want to underscore is the aspect of Jewel on the professional side. So employee engagement. We have a shared collaborative governance here, a collaborative governance, meaning different councils, different committee. Every single committee, every one of my staff are on a committee. I don't have one staff that's not on a committee. I don't have a staff that's not responsible for whether it's a local project, whether it's an organizational project. I have a representation on each and every single project within the organization, whether it's getting someone that's in charge of making sure all our nurses, our PCAs are certified. So I have a male nurse that's in charge of making sure all the CPR, everyone is CPR, has not expired. He keeps track of that. I have someone that runs the resource nurse meeting, which is a charge nurse meeting. I have someone that's in charge of the unit coordinator meeting agenda. I take a step back. I've read this saying that you hire the most important smart people, let them do their job and sort of stay out of their way. So we have to remember to stay back to the basic on just allowing staff to just engage in what the hospital has to offer, engage what the unit has to offer. And so wellness and well-being is not just wellness and well-being, it's the whole bundle of Jewel is what I find to be sustaining a culture that we want to maintain, whether it's during a crisis or not during a crisis, because when it's during the crisis and you haven't established Jewels, it becomes harder to navigate the crisis. The other thing that I thought was extremely important to also highlight, and it's back to the basic, is not just the term bring back basic. It was officially coined 6 years ago at the Sendai Conference on Disaster Risk Reduction. I don't think it's on my reference, but I can definitely send it to Isabel, and then she can forward that to all of us. The other thing I want us to think about as we leave, as I close out my presentation, is there's a really awesome video on how cats and dogs navigate their way, and I'll also send that to is I remember during the pandemic, everyone said, Marie, you act like a cat, the way you walk, the way you talk to us, and I felt really great about that, So every now and again, I will pull into the nursing station and I would say, here she comes, the eloquent cat, So it's maintaining that similarity or behaviors between a cat and a dog when it comes down to crisis or a moment of uncertainty. So thank you everyone for allowing me to be in this space today. And I just want to leave with, if the past 2 years showed anything, it's that we should be prepared for the unexpected, to tackle uncertainty without loss of composure. In doing so, we could inspire our teams and loved ones to also shrug the small stuff and dare to explore paths untrodden. Thank you so much.
Thank you so much, Dr. Borgella. Let me see. Can you all see my screen? Okay.
Yes.
Okay, Good. Thank you so much for all these wonderful presentations. Now I would like to ask you to please ask any questions you may have. I know Dr. Pandia was asking, how can we engage and interest health profession students in careers in gerontology? I don't know if Dr. Carmody or Dr. Phillips, Dr. Porgella, you want to tackle this question?
I will start, and I know Dr. Phillips and Dr. Porgella have great ideas. I love those presentations, and oh my gosh, I was a previous system chief nurse, and to have nursing directors, oh my gosh, Marie, amazing. Congratulations. And Dr. Phillips is an inspiration, and she can tell you how to get interested in gerontology. But I want to just throw one thing out about that, maybe two things. One is that ageism is everywhere. So the idea that you would go into school to study aging, or to be a gerontologist, or to be a geriatrician, or to be a nurse practitioner that focuses on geriatrics just is hard to begin with because of the ageism. In your own family, you might want to make sure that that your young ones have an experience with older people. And I don't mean just people in a nursing home, but people in the community and how they can engage, because it is that creates. But specifically, the foundation has a grant with Case, well, but that's another one, has a grant with the Jewish Foundation in Pennsylvania, and it's called Return to Teaching Nursing Homes. That is a pairing of a nursing home and a academic nursing program, and there's assigned clinical space and assigned programs and discussions about caring for older people, because for the most part, people say, well, none of the students want to go into gerontology. None of them want to go into works in a nursing home or in community settings with older people. So that was one way, and it's been very successful. So watch that in Pennsylvania, more things to come. And we hope that we'll make a big impact in improving that relationship and that effort, that engagement of students in care of older people. And I'll turn it over to Dr. Phillips.
Jane, you definitely nailed it. I think the initial challenges is this preconceived notion about older adults are, and I'm using quotes because I don't use this language, frail and elderly, and we don't, they're at the end of their life and there's not much left. And it's like, no, there's a lot left and there's a lot of engagement. Whenever I'm exposing my students in a public health course to aging, I start with a picture of Ernestine Shepard. I don't know if you all know who she is. I had the pleasure of being outrun by her many years ago at the Baltimore Women's Classic. She is this super fit 80, I think she's like 86, 87-year-old woman who started bodybuilding when she was in her 70s. And I always say, now, is this what you think of when you think of working with older adults? And they're like, well, no. And then I don't know if I ever told you I do this, Jane. I have a picture of my principal from kindergarten and first grade who wears heels, still drives her Mercedes, and she's 90. She's 90. So I always, in my own way, reframe that narrative of what it means to work with older adults, because I think that is a big part of it. It's this idea of the nursing home image, or that there's not a lot of opportunities, but also beyond that, early in my career, people thought, oh, you just want to go work in a nursing home. And I said, no, I want to focus on helping older adults live longer and healthier wherever they want to live. And that means a lot. I think that one of the things is that we have to do is expose the opportunities. There's so many opportunities to intersect. Even if you're not working directly with older adults, there's still opportunities to intersect. Sorry, I lost my signal. I hope I'm still here.
You are.
Okay, sorry. They're doing construction in our building, so I keep losing things. But the opportunity to just expose and show people the different opportunities to work in support of older adults or in the field of aging. So for example, you have the opportunity to do community-based work. I know that's something that a lot of people are interested in, but they don't know that that's an opportunity to work in housing. That's an opportunity to work in faith-based communities. Their opportunities are limitless in terms of intersecting with older adults. And also, I think before I wrap up, the importance that at some point you're going to end up interacting with older adults, whether that's your plan or not. I always tell people with affordable housing, I know that's my framework, but a lot of people move into housing communities when they're in their 30s and 40s, and they stay there. They don't leave. And you're now in a situation of you're dealing with people that are in their 60s and older. And how do you help them if they started there when they're older, but they have aged in place and they're staying there? So again, you may think that you're not going to interact with older adults, but they're going to be there and they're going to age there in these communities. But again, thinking about ways that aging intersects with all different sectors, I think is showing people the opportunities. Because I think right now we just think of contained, very stereotypical opportunities with older adults, when the opportunities are really vast and pretty exciting as well.
I love students. I think sometimes they don't know what they don't know. Just like I think of my my PCAs or my CNA or my clinical assistants or my student nurses who really do not know where they want to land in the nursing profession. I always say, why don't we talk about why you don't, why you do? Why don't we talk about a shadow? In this situation, I think I would probably say, why don't I connect you with a gerontologist? Why don't I set up a shadow for you so you can see why you might want to do it? You know, and usually sometimes I would end up getting I love it, or I know I don't, but at least I know they've tried it before they say that they don't want to do it or they're not interested. Well, you don't really know what you don't know. So why don't we set up some ways to help you really, understand if that's what you really don't or want to do.
I know Dr. Pandya just raised her hand.
Yeah. Thank you so much, Isabel. Actually, everybody, on behalf of the NSU QEP, I really want to thank Urban Health Partnership and all the great speakers and the sessions that we've had. I think it's been a really eye-opening and great opportunities for collaboration will come out of this. But I really appreciate the discussion about engaging health profession learners in careers in geriatrics and gerontology and the ideas. But it still strikes me as I think we have to model those of us who are in this profession, how interesting it is and how rewarding and actually how intellectually challenging it is to take care of older adults. It's not a soft profession, and as there's a post that says it's not for sissies. You really have to stay the course, be very knowledgeable, and not only in medicine, but all the other aspects of caring for older adults. So I think that we somehow have to elevate in the media, in our communications, through social media, the complexity of this profession and the interest and lifelong rewards that it can bring. Look at this, all the participants, most of us are women here. And why is that? Do we still see ourselves as the softer, caregiving role? But this is, as most of you know, this is a hard and challenging profession, and yet it attracts mostly women. I had a medical student standing in the cafeteria behind me, he's a young man. He said, "Oh, I think I'm interested in geriatrics." I nearly fell over and I bought him his lunch. Anyway, I'll stop there. Thank you so much.
Thank you, Dr. Pandya. I know we have one last question, and I do want to wrap up on time, but Janice Davis, our program manager, was asking how to get employers to recognize the importance of employee well-being, especially when many employees are doing two jobs due to high turnover, but only receive compensation for one. Any suggestions?
Isabel, if I can clarify, for older people, employers, yeah. Older or in general?
I think it would be for both, but okay. You can focus on your area of expertise since we're talking to, health providers.
Well,
So
I think this is Maria's area as well as Karan's, but I'm just going to add in here that we are, as we mentioned, we're kind of looking at the infrastructure, the ecosystem of age-friendly and diversity, equity, and inclusion. And one of the groups we work with, and I put it in the chat, is Age-Friendly Institute. This group has already has a certification process in place for employers who are age-friendly. And they have it's a real helpful, they have a whole listing of things that are important to older people: flexible schedules, work that matters, mentoring and supporting. And so I think if you're very interested more in that, that might be a great website. But I would have to applaud Maria, because it is hard, and you want to not only provide skilled work that matters and it's important to people, but to make sure that there is joy at work. And I found that just so fascinating, that the work that you did. We always measured in my previous roles, not in this foundation role, but as a assistant chief nurse, we always used the joy scale, the NDNQI, because we knew how important that was. And I loved it that you had everybody on a committee. That is what it takes. It's engagement, it's accountability, and that brings us pride and joy. So thank you so much for all the work you're doing there. That's my thoughts. Isabel, I'll pass it on.
Perfect, thank you, appreciate it. And with that, I think we conclude this amazing training that we've had with the 4 sessions. And here is the contact information for 3 speakers today. And we'll share the PowerPoints and the recordings with everybody, send you the certificates of completion when this is done. But if you have any other questions, feel free to email me or any of our speakers, and we'll be sure to reach back to you with answers to your questions. Thank you so much, appreciate it. We'll be in touch.
Thank you so much for having us. This is such a great session, and the series has been wonderful. Thank you so much.
Thank you.
Thank you.
And thanks for all you're doing too, in the work that you do every day with this great web.
Thank you.
Absolutely.
I think my screen froze, but bye everybody. Thank you so much.
I'm trying to leave, but it's not.